Okay, good morning. So I was tasked to talk on SARS-CoV-2, its variants and vaccines, no? But I decided to also discuss a little on the disease that is caused by the SARS-CoV-2 itself, no? Which presents in many different manifestations in patients. So I entitled the topic as vagaries, variants, and vaccines. So as we all know, COVID-19 or the coronavirus infectious disease is caused by SARS-CoV-2, which is a newly emergent coronavirus, which was first recognized in Wuhan, China in December of 2019. And as of February 28, 2021, there have been about 115,000 cases, and the number of deaths is at 2,540. So transmission is, wait, I'll just, there, okay. So transmission is from person to person through respiratory droplets, which is generated by exhaling, especially when it's done vigorously, sneezing, coughing, singing, and speaking. And the relative contributing role of aerosols is still unclear, but is much less important. And indirect transmission through fomites that have been contaminated by respiratory secretions is also possible. That's why it is recommended that we wash our hands and that we wear our masks. So viral shedding is identified in this respiratory specimen, no? Even 1 or 2 days before the onset of symptoms. And we call this pre-symptomatic viral shedding. And it can persist up to 8 days in mild cases and even longer for those with severe and critical cases. And they said that it can be shed up to 20 days from the onset of symptoms. So the incubation period is the period from the time that the patient acquires the virus until the time that the manifestation is noted. The mean incubation period is 5 days. But 97.5% of those who will develop symptoms occur within 11.5 days. That's the reason why the quarantine period for patients who are exposed to the virus is set at 14 days so that we can observe, because sometimes the symptom may set in on the 10th day or in the 11th day. So there are 3 stages of the infection. And the first stage is the early infection, which is marked by viral response. So it may be manifested as fever, dry cough, mild constitutional symptoms. And most patients are actually only have this stage of the infection. But some will proceed to the next stage, which is the pulmonary stage, and it is associated with shortness of breath, with or without hypoxia or decrease in the oxygen saturation in the blood. And then even a smaller subset of patients also proceed to the hyperinflammation phase, which is associated with acute respiratory distress syndrome, shock or drop in the blood pressure, and respiratory failure. The disease is classified into mild or asymptomatic, moderate, severe, and critical. So we usually classify our patients in the hospital with these disease classifications. And this is also where the PhilHealth gives their coverage for those who are hospitalized based on this classification. About 10 to 20% of symptomatic infected individuals develop more severe disease. No? So that's only about 10 to 20% of those who are infected. And 2% of those infected will succumb to death. Diagnosis, apart from having the clinical diagnosis, of course, it is confirmed by RT-PCR. No, where the patient is swabbed and then this is sent to the laboratory for detection of the antigen by RT-PCR. The recently released rapid antigen test can also be used as a diagnostic tool for patients. So in the latest guideline, it was said that patients who have symptoms that is consistent with coronavirus disease plus a rapid antigen test, it is also considered to be confirmed to have COVID-19. So treatment is mainly supportive. So patients can be given paracetamol for the fever, mucolytics for the cough, and for if patient have colds, then the congestant, or but if patient manifests with body aches, then they may be given analgesics. So antivirals are also given, especially those who are hospitalized. So we have the remdesivir, which is the IV antiviral, and the favipiravir, which is the tablet form. We also give steroids for patients because of the inflammatory response that the body has against the virus. And to some extent, the inflammatory response is really great. So we try to control the inflammatory response by the use of the steroid. And there's also another drug, which is the tocilizumab, which we give for those who have severe infections. And once we see that the patient may manifest a beginning cytokine storm, then we give this drug. So we only give this for those subset of patients because it's an expensive drug. So it costs about 28,000 per dose. And then we also give low molecular weight heparin because patients have the tendency to form clots in the blood. So we give these to patients. And there's also hemoperfusion where the same machine as the dialysis machine is being used, but a different cartridge is used. And the purpose is to really filter the inflammatory mediators that is released by the body during the infection. Convalescent plasma has also been used, but studies have not really been very conclusive about its benefit in patients with COVID infection. So recently, NMC has already started extracting blood to those who have recovered from the infection. And then we also have the extracorporeal membrane oxygen therapy, which is actually not available in Cagayan yet, but it is also an option for those with critical infections. So this is a picture of a patient who has recovered from the disease. And then so we asked, so unlike in other diseases or infections where when the patient is noted to have improved and can be sent home, then they are immediately sent home to their places. But it's different with COVID because once the patient has recovered, they still have to comply the number of days that the patient has to be isolated, and then we send them home. So it's either we send them home if they have complied the number of days required for isolation in the hospital, or we send them to that treatment and monitoring facility to complete their isolation there. So we asked, when can patient be sent home, really, those who are diagnosed with COVID, and is there a need to repeat the swab? Because this is a common question that patients ask us when they are well already and can be sent home. So this slide will show you the Omnibus Interim Guidelines on Prevention, Detection, Isolation, Treatment, and Reintegration Strategies for COVID, which was released in October of last year by the Department of Health. So it says the discharge criteria for suspect, probable, and confirmed COVID-19 cases shall no longer entail repeat testing. Now, repeat testing should not be a prerequisite for the issuance of a clearance or certification to be issued by medical doctors. The reason for this is that studies have shown that even if the virus can be detected by RT-PCR, even 2 weeks or even 3 weeks after the onset of infection and the patient has been clinically well for several days to weeks already, some patients' RT-PCR result will still come out positive. But there was a study which did an RT-PCR and viral culture at the same time, and they were able to show that the virus can be cultured actually up to the 6 to 8 days from the onset of illness. Beyond that, they cannot culture the virus anymore. So it means that the RT-PCR positivity result just detected the antigen but not the live virus actually. So patients with mild symptoms who have completed at least 10 days of isolation from the onset of illness, either at home or a temporary treatment and monitoring facility, and this is inclusive of 3 days of being clinically recovered and asymptomatic, can be discharged and reintegrated to the community without the need for further testing, provided that a licensed medical doctor clears the patient. For patients with moderate, severe, or critical symptoms who have completed at least 21 days of isolation in the hospital from the onset of illness, inclusive of 3 days of being clinically recovered and asymptomatic, can be discharged and reintegrated to the community without the need for further testing, provided that, again, a licensed medical doctor clears the patient. So for those who have been swabbed, but they have been asymptomatic and whose RT-PCR result turned out positive and remained asymptomatic for at least 10 days from the onset of specimen collection, can discontinue isolation after 10 days and be tagged as recovered, confirmed case without need for further testing, provided that a licensed medical doctor certifies or clears the patient. So this is actually really very clear in the omnibus guideline, but unfortunately, there's still a lot of confusion in the community because many patients really also want to be tested still. No? So because they want to be assured that they are really negative, and then many patients needs to stay also in the different facilities and they cannot be sent to their homes because of this fear. So an update taken from the Centers of Disease Control said that the concentrations of SARS-CoV-2 RNA in the upper respiratory specimens decline actually from the after the onset of symptoms. So starting on the first day that the symptom sets in, then slowly in the next few days, the viral shedding declines. And the likelihood of recovering replication competent virus also declines after the onset of symptoms. So for patients with mild to moderate COVID-19, replication competent virus has not been recovered after 10 days following symptom onset. And the recovery of replication competent virus, meaning a live virus between 10 to 20 days after symptom onset, has been reported in some adults with severe COVID-19, only with severe COVID-19 or those with critical COVID-19. So in this series of patients, it was estimated that 88% and 95% of their specimens no longer yielded replication competent virus or live virus after 10 and 15 days respectively following onset of symptoms. So that it's really okay to send the patient home because we know that patients' viral shedding really declines after the onset of symptoms. So by the 10th day, most likely the patient is really no longer infectious. And in a large contact tracing study, no contacts at high risk of exposure developed infection if their exposure to a case patient started 6 days or more after the case patient's infection onset. So that means if you have been exposed to a patient after a week from the onset of illness, in these studies where there was contact tracing of these contacts, they have seen that there was no secondary infection to those who were exposed 6 days after the onset of symptom in the index cases. So recovered patients can continue to have SARS-CoV-2 RNA detected in their upper respiratory specimens for up to 12 weeks after symptom onset. an investigation of 285 persistently positive adults, which included 126 adults who have developed recurrent symptoms, found no secondary infections. No? Among 790 contacts of these 285 persistently positive adult patients. So the CDC recommends that all people, regardless of symptoms and regardless of whether or not they have had laboratory confirmed COVID-19 in the past, continue to use all recommended prevention strategies to prevent SARS-CoV-2 transmission, which is actually wearing your mask, social distancing, and avoiding crowds and washing hands regularly. So we have what we call the post-acute sequelae of SARS-CoV-2 infection, because we have, I'm sure some of us have read that there are patients who still manifest symptoms weeks or even months after they have had the infection. And this can be manifested as fatigue, shortness of breath, cough, joint pain, chest pain, and others patients, they may manifest as having difficulty with thinking and concentration. Some will have muscle pains, irritations, and these can last for weeks to months. And this is more commonly seen in females. And it was initially thought that this is seen in the elderly age groups, but recent studies have shown that it's also seen in young individuals in the third to fourth decades of their lives. So we also have heard of the variants now of SARS-CoV-2 virus. And so what are these? No? So viruses constantly change through mutation. Mutation rate is the rate at which errors are made during the replication of the viral genetic material. And mutation rates are clearly subject to natural selection and can evolve over time. So all RNA virus to which the SARS-CoV-2 belongs mutate over time, some more than the others. And many viruses have high rates of evolution due to large population of the viruses, the short generation times of the virus, and the high mutation rates of this group of viruses. So this slide will show you and this is an illustration, of how the virus will mutate. So you have a virus there. You see the left side of the illustration, and you will see that there are two viruses here. The one with the red genetic material, and the other is with the blue genetic material. So both of these viruses can infect the host cell. So this is the host cell. So the virus will make use of the machinery of the host cell to replicate its genetic material. So they will make use of the RNA polymerase. So the genetic material is replicated. So you will have two genetic materials here. But the RNA polymerase may also have errors in detecting the end signal of the replication. So they may, here, the RNA polymerase is still attached to the genetic material of the virus with the red genome, and then it attaches also to the genetic material of the virus with the blue genome. And then it mixes the genetic material, and then it senses the end signal for replication. So as a result, you may have genetic material, which is a hybrid of the one with the red and the blue genetic material, and you also have a virus which is the original genetic material. So you will have viruses here with the red genome and the blue genome, and you have a mutated virus there. So that's how the virus mutates. So I think I will only discuss, the others are for the different kinds of virus, but we will just focus on the non-segmented RNA virus. So SARS-CoV-2 variant is a new virus variant that has one or more mutations that differentiate it from the wild type or the predominant virus variants already circulating among the general population. So there have been a few identified, the B117 in the UK, the B1351 in South Africa, the P1 in Brazil, and the P521 in New York, no, which is similar to the South African variant. And currently, there is no evidence that mutations have any effect on the disease severity, but possibly on the infectivity of the virus. They said the UK variant may be more infectious compared to the wild type virus. So this table will show you the different variants, their mutations, where they were first identified, and then whether they confer increased transmissibility. So for the UK, it was confirmed to be more infectious compared to the wild type, and for the South African, there is evidence that suggests that some mutations may affect its transmissibility. So the impact on severity of disease or vaccine efficacy, there is no evidence for most of the variants. But for the South African, there is evidence that suggests that some mutations may affect its antigenic profile, which may affect the ability of antibodies to recognize or neutralize the virus. So what are the potential consequences of emerging variants? So it may have an effect on the ability to spread more quickly in people. So there is evidence that the 614G variant spreads more quickly than viruses without the mutation. And it may also have an effect on the ability to cause either milder or more severe disease in people. So it was noted that there's an increased risk of death in the UK variant. And there's also the effect on the ability to evade detection by specific viral diagnostic tests. But studies have shown that the recent test can still detect these different variants that has been identified in the different places. And there is also effect on the decreased susceptibility to therapeutic agents such as monoclonal antibodies, because these antibodies were supposed to be manufactured to detect specific antigen of the virus. But so if there's a change in the viral antigen, so there is a potential that this might not be detected by these monoclonal antibodies. And there's also effect on the ability to evade natural or vaccine-induced immunity. The virus would likely need to accumulate multiple mutations in the spike protein, because this is really the target of our immune system, the spike protein of the virus, to evade immunity induced by vaccines or natural infection. So currently, there's still really no the studies have not shown that there is really a need to change the vaccine so to be able to target these new variants, because they have seen that it's still effective against these new variants that have been identified. I think that's the last slide for the first set.
Okay, thank you very much, Doc Arlene Obshoma. We will have you again after our second resource person will be able to share her inputs as well for this morning's webinar. So Doc Arlene, thank you very much for your first presentation. We look forward to the next part of your presentation. So please stay on. Thank you. There are questions that are already raised here in our chat box, other than, of course, what had been raised in the pre-registration link. So again, we will have an open forum after all the inputs are shared. So if we can hold on to these questions until after the presentation. So thank you very much. So again, Dr. Arlene, thank you very much for your first presentation. Can we give Dr. Arlene a round of virtual applause, please? Thank you very much. Sige. So let us proceed. Our second topic is entitled Herd Immunity, Understanding the Science of Ending the COVID-19 Pandemic. Our second resource person is a medical doctor by training. In fact, she doesn't need an introduction because she's one of our own. So she is an associate professor in the Department of Preventive Family and Community Medicine in our own Jose P. Rizal College School of Medicine. She teaches epidemiology and research methods. Concurrently, she is also the director of the Center for Global Health, an outreach unit of the School of Medicine. And she also works with the Northern Mindanao Medical Center as the institutional research coordinator and as the chair of the Research Ethics Board. As a public health expert in the region, she is involved in many research and development projects on water, sanitation, and hygiene, on child nutrition, disaster management, public health policy, biosafety, and biosecurity. We will not make this long. She does not need a long introduction again. She is our friend. She is our colleague. Please let us all welcome our very own Dr. Gina Itchon.
Good morning.
Our round of virtual applause, please.
Can we stop share the slide for
Doc Arlene, can you
Okay.
end slide share, please, so that Doc Gina can also share her screen?
Understood.
Good morning. Okay, I hope you can see the slide now. The slides now.
Not yet, not yet.
Yes.
Yes, Nana Doc.
Okay, so there you go. So this was my task, no? Gamay lang correction kang Gail. Professor na ko karon, no? Na promote na ko. Okay. I was promoted in December, so very new. So one of the terms that you hear very, very often in media is herd immunity, no? And that was my task. I was tasked to discuss this. What is this, no? Because this is actually our hope for ending this COVID-19 pandemic. So I will basically take up these topics, review of the COVID-19 timeline, which Dr. Arlene also did, no? And then how infections propagate, how infections end, and a little bit about vaccine hesitancy, because this is actually our biggest barrier now to achieving herd immunity. So very quickly, no, this was the start of the pandemic last year, when nobody wanted to believe what WHO was saying. In a period of 2 months, actually, so from December 2019 to January 2020, the infection spread very fast all over the world. And this slide shows how the countries were affected. By January 20, there were only 4 countries affected with the disease. By February 15, there were 28, including the Philippines. By March 1, 2 weeks after, there were 66. And by March 20, it was all over the world. No? It was very difficult to find an area that was not affected with COVID-19. So that is how we are now. No? And fast forward to a year after, this is the Coronavirus Resource Center of Johns Hopkins. I accessed last Sunday when I was doing my slides, February 27. So a year after, this is how we are. No? Global cases are about 113 or 114 million, and our deaths are in the 2 million, no? 2 million plus. And again, the map shows everything, all the areas being, almost all the geographical areas being impacted by this disease. So how do infections spread? No, in general, how do they spread? Okay, this was, again, Dr. Arlene referred to this. So we have general transmission. You can have the disease agent coming from the environmental areas, from the environment. So you can have wind directly from the wind and directly from the water impacting people, no? Or it can pass through animal vectors. So as in the case of malaria and dengue, which passes through mosquitoes, or bubonic plague, which passes through fleas. But then the more common mode of transmission is actually human to human transmission, no? So we have direct contact, where the pathogen has to be introduced directly from one person to another, no? HIV is like this. It's introduced by sex or by needle stick, no? And then we have indirect contact, where the pathogen survives the environment, no? This is where fomites come in, no? So you can get the infectious agent through doorknobs, through light switches, etc., etc. And then droplets, no? Where the pathogens are in respiratory droplets, but they do not survive long. And then airborne, when the pathogens are aerosolized and stay infective for more time, no? And then fecal oral, or when the agent is passed through water or through food. So for COVID-19, uh, it is thought that indirect contact, droplets, and airborne play a role, although these are not really very clear yet which one really plays a big role. No? So that's why we are we are told to wash our hands, we're told to wear a mask, we're told to wear a face shield even, no? Because we're trying to address all of these methods of transmission. So an infection propagates itself by transferring to other susceptible hosts. That's how it spreads, no? From one host to another. And susceptible hosts are those who are easily infected, having no or not enough immunity to fight off the infection. Now, for COVID-19, all human beings were susceptible in the beginning of the pandemic, since we were dealing with a new disease. So nobody had immunity at all in the beginning, uh, last year. No? People who have been infected with COVID-19 form antibodies against the disease. And getting infected is one way of developing immunity to an infectious disease. So 1 year ago, we did not know that there would be vaccines that were going to be developed. So the only way really that you would get, that you had hope of developing antibodies, is when you get the disease itself, no? And it was very tempting to think this, no? With COVID-19, can we wait for people to just get infected so that they develop the antibodies for protection? So that's what people were saying, no? That let everybody get COVID-19 so that they will develop the antibodies, and then they will be, and we can control the infection. That was a very tempting thing to think about, no? But my if we did this, at what cost? No, we can wait for people to get infected, but then people will die, no? And the mortality rate was very high in the beginning of this infection, because even us doctors, we did not know what to do. We did not know how to manage the persons with the disease. So, however, we have a choice. No, once the vaccines were developed, immunizing people is another way of making more people develop antibodies. This is faster and safer because antibodies for protection are developed without experiencing the full-blown disease. So you develop the antibodies, but you don't experience the full-blown disease. And so it's safer, you don't die, no? How many people do we need to vaccinate? So that's, again, that is a question. If we vaccinate, how many people do we need to vaccinate? And that's where once we start talking of herd immunity, that's actually a sign that the end of the pandemic or the epidemic is near. So herd immunity is, or community immunity, no, is a form of indirect protection from infectious disease that can occur when a sufficient percentage of a population has become immune to an infection, whether through vaccination or previous infections, thereby reducing the likelihood of infection for individuals who lack immunity. Now, this percentage is determined scientifically and involves the use of the R0 or the transmissibility factor. No? For COVID-19, this has been determined to be around 70% of the population based on the R0 of 2 to 3. If you have an R0 of 2 to 3, meaning one infected person is capable of transmitting the disease to 2 to 3 other new susceptibles. No? So that's the R0. And it's actually very simple. No? If you have if you have a population with no herd immunity, there are no immune individuals, it is very easy to pass on the infection to others. So if there are no people who are immune. If enough people get sick and survive, or enough people get immunized, then you achieve herd immunity. Each of these green guys are actually barriers to the disease. The virus or the bacteria finds it more difficult to find another susceptible because there are more people who are immune. No? So that's what herd immunity is. Very simple. Another picture. If only a few people are vaccinated, so you have a whole lot of susceptibles, the ones who are colored gray. If you have one infected person, it is so easy to pass on the infection to others because there are few people who are immunized and who cannot get the disease. But if lots of people are vaccinated, so you have one infected person in orange, and it will be more difficult for that disease agent to be passed on to another susceptible individual. Then the disease can spread very far and the whole community stays safe. That is what herd immunity is. No? So in other words, if we get ourselves immunized, we are actually protecting also other people in other susceptibles in the community. So this is from Bloomberg, no, and this was when we did not yet know enough about the disease. So a novel pathogen is introduced to the community, and because it's new, no one has immunity and it begins to spread. This was how COVID-19 was in the beginning. Those who recover and those who receive a vaccine, if there is one, develop immunity, at least for a period of time. With the coronavirus, it's not known how long. Even up to now, we don't know. If we get the vaccine, do we have to get it every year? Do we have to get it every 2 years? Do we have to get it every 5 years? We do not know. So far, there is no proof. Well, when this was written, there is no proven vaccine. Right now, there are quite a number of proven vaccines. Herd immunity takes hold when the pathogen can't find new hosts and stop spreading. That happens once a sufficient portion of the community is immune. And for this virus, it is estimated between 55 and 82%. At this time, they really were not very sure yet. No, this was around August of last year. Right now, we can say it with more specificity, and it's actually between 65 and 75%. If enough people are immune to a certain disease, every immune individual acts as a barrier to the transmission of disease. And an epidemic or a pandemic ends when the causative agent could no longer transfer to a susceptible individual and it dies out. No? Wala na siya'y mabalhinan, so it will die. The only actually barrier to achieving herd immunity is when there are not enough immune individuals. No? If, for example, many refuse the vaccine, or heaven forbid, the vaccine we receive is spoiled. So we do not want that, no? So what is vaccine hesitancy? I tried to look into the reasons, no, into a study why people would not want to receive COVID-19 vaccination. This is what I found. This is from the U.S. Department of Health and Human Services, no? Which is the counterpart of the DOH in the U.S. And it's interesting what the reasons are. No? This is as of December 2020, so quite new. So the top reason why people do not want to receive the vaccine is they're worried about possible side effects. So that's 59%. They do not trust the government to make sure the vaccine is safe and effective, 55%. And the vaccine is too new and they want to wait and see how it works for other people. That's 53%. And 51%, thanks to President Trump, politics has played too much of a role in the vaccine development process. So those are the top four, no, that comprises more than 50% of respondents answering these choices. It would be interesting how it will be in the Philippines if we conducted a similar study, no? So what is my takeaway message? As members of a university community, it is our responsibility to educate others about vaccination. And really, it is our moral responsibility, no, to be vaccinated. We must contribute to Cagayan de Oro achieving herd immunity by having ourselves immunized. So I'd like to end with this slide. This is from Dr. Bolberding, who is a faculty member of the UC San Francisco School of Medicine. Very simple man ang iyang gisulti, no? I'd much rather have a vaccine than have the virus. So very practical. And that's my topic. Thank you very much for your attention and your time.
Thank you very much, Doc Gina, for that very informative, no, and very substantive input on herd immunity and the importance of really getting vaccinated. So it is not actually just in the US, maybe, Doc Gina, that the side effects is the leading reason for the apprehensions of people to subject themselves to vaccination. Okay, in our generated answers here, no, from our participants today, it's also the questions on the vaccine and the vaccination, subjecting oneself to vaccination as among the reasons here for answering maybe to subjecting oneself to vaccination. Sige. So thank you, Doc Gina. Please stay on for the open forum after the second presentation of Doc Arlene. So thank you very much. Can we give Doc Gina a virtual round of applause, please? Sige. So thank you very much. At this point, let us call back again Doc Arlene of SHOMA to present to us the available vaccines that are in the market. But although it's still scarce at this point, let us try to see what are available and what are the recommended ones, at least for us, what the doctors really recommend for us. Sige. So thank you very much. Doc Arlene, it's your turn now.
Yes. Thank you. Can you see my slides now?
Yes.
Yes, Doc.
So now we go to the different COVID-19 vaccines. So we asked the question first, no? So this was partly discussed by Dr. Gina already. So vaccines greatly reduce the risk of infection by training the immune system to recognize and fight pathogens such as viruses or bacteria. And vaccines safely deliver an immunogen, which is a specific type of antigen that elicits an immune response to train the immune system to recognize the pathogen when it is encountered naturally. So we have mentioned earlier, so why do we need vaccines? Because there are a lot of individuals infected already, and we have already had a lot of people dying from disease. So we really need to stop this infection and this pandemic. And that is really mainly through the administration of vaccines. So vaccines can prevent infectious diseases. Example of vaccine preventable diseases are the measles, polio, hepatitis, influenza. So we have all these vaccines, and probably many of us have had these immunizations already. And when most people in a community are vaccinated against the disease, then the ability of the pathogen to spread is limited. This was mentioned by Dr. Regina. And when many people have immunity, this also indirectly protects people who cannot be vaccinated, such as the very young babies and those who have compromised immune systems. So how are vaccines made? There are three main approaches to making a vaccine. No? So first is using the whole virus or a bacterium. And then there's also the second, which uses the parts of the virus. And for the SARS-CoV vaccine, they make use of the spike protein. So this is the one that triggers the immune system. And other vaccines also make use of the genetic material of the virus. So using the whole microbe approach, we also have the inactivated vaccine, no, where the virus is subjected to chemical exposures that inactivates the virus, and then they administer it through the vaccine. We also have the live attenuated. So this is the live virus is injected, but it is made weakened or attenuated so that it will not cause the disease that the virus causes. And then we also have the viral vector vaccine. No? So they make use of another virus that is not able to multiply. And then so they put the genetic material into that virus, and then they use that for the vaccine. So the subunit approach, as we have mentioned, uses the spike protein, and it only uses the very specific parts of a virus or bacterium that the immune system needs to recognize. And then we have the genetic approach, which includes your mRNA and the DNA vaccines. So this is the life cycle of the vaccine. No? So we have to remember that safety is always a priority during the vaccine development and approval. So in the beginning, when in the different companies, the laboratory would search for about the disease, what can be done to contain the spread of the disease. And then when they discover an antigen that can potentially stop or stimulate the immune system of the individuals to be able to fight the infection, then they do preclinical studies of this vaccine. So they test it on animals. So when they see that there is no severe adverse reactions in animals, then the company then submits their investigational new drug application to FDA, Food and Drug Administration. So the FDA rigorously reviews the materials that were submitted to them to see and to ensure that the vaccine that is being applied for is really safe for use. And so when it is approved, then it is subjected to the phase 1 trial. So the phase 1 trial, this is tested to healthy individuals. So about 20 to 100 individuals are being tested using the vaccine. And when they see that there is no reaction, you know, in the trial, then they will proceed to the phase 2 trial, which will assess more of the effectiveness of the vaccine. So they will look into the immune response of the different individuals to whom these vaccines are administered, and then they measure the antibody response and even see if these individuals will develop infections when they are subjected to the virus. And then when this is completed, then they proceed to the phase 3 trial, which also assess the safety and effectiveness. So this is done in a greater number of people, uh, hundreds of thousands of individuals. So this may include now the vulnerable individuals, because in the phase 1, this is only done in the healthy individuals. So for the phase 2, some selected vulnerable groups may be included. And in the phase 3 trial, all groups of or subsets of individuals are represented. And so they will know if this is really effective for all subgroups of people. So when they are done with the phase 3 trial and they see that the vaccine is really effective and safe, then the FDA will again review the information when the company submits the biologics license application to FDA. So the FDA will review, and then after a rigorous review of the documents submitted, then the FDA will approve. And once this is approved by the FDA in the US, the Advisory Committee on Immunization Practices will then make guidelines, to whom and how these vaccines will be used. And so the ACIP will release their recommendation as to the use of these vaccines. So these vaccines will then now be marketed. So this will be distributed to different places, different countries. And then once these vaccines are already marketed and used in different individuals, continuous monitoring of the possible adverse reaction is also still done. So safety monitoring for serious and unexpected adverse events are also done in the phase 4 of the vaccine development. So post-approval monitoring and research are being done in the different countries. So this will show you, a different illustration of the number of people that's involved in the different phases of vaccine trials. So for the phase 1, only about 20 to 100. So in the phase 2, there are more people that's being tested, given the vaccine to, and then for the phase 3, there are more, hundreds of thousands of people, and then after the phase 3, once it's approved, then it's used for everyone that the vaccine is recommended to. So what is emergency use authorization? So a medical product or a vaccine is made available before a full application is approved by the FDA, just like what happened to the COVID vaccine, because we cannot wait anymore for the phase 3 trial to finish, which will take about 5 to 7 years. From phase 1 to phase 3, that will take about 7 years. So we cannot wait for that duration to be able to make use of the vaccine. So maybe by that time, the mortality would really have risen, and many individuals will be infected with the virus, and the healthcare community will really be overwhelmed with the number of individuals being infected. So to receive an authorization for emergency use, vaccine developers must demonstrate that the vaccine's known or potential benefit outweighs the known and potential risks. So this is not a lower standard, but a more tailored, flexible standard that helps protect those who need it most, while more evidence is generated needed to make the public confident about getting a COVID vaccine. So this is a different illustration of the vaccine development. No? So you will see in the research period, it will take 2 to 4 years. For the preclinical studies, that takes 1 to 2 years. For the phase 1, that will take 5 to 7 years. No? And then it's being approved. And then so it's going to be manufactured by the company. There's also marketing and administration. That's the phase 4 of the vaccine development. But for the pandemic accelerated model, so this is what happens. No? So research was done the start when they noted the virus, and then there was preclinical trial already. And then while the preclinical trial was still ongoing, they already started with the phase 1 trial. So they started it with the healthy individuals, and then they proceeded to give it to vulnerable individuals, and then the phase 3. So while they were still in the phase 2 or 3, manufacturing was already started. So that when the result will come out, then it's already ready for distribution to the different countries. So there's administration, and then there's also phase 4 of the trial, while manufacturing and distribution of the vaccine is done. So this is an illustration of the different vaccines. Maybe we will not go through. Just to emphasize that RNA-based is for Pfizer and Moderna. And then we have the Sinovac, which is the one available in Cagayan de Oro, which is an inactivated virus. No? So this is a killed pathogen that cannot replicate itself. So we will now go to the different, to the individual vaccines. No? So we first discussed the Moderna, no? Which is an RNA vaccine. And then this is given in 2 doses, and it's given intramuscularly. So the dose interval is 28 days between the first and the second dose. So the difficulty with this, needs to be stored in a freezer at negative 25 to 15 degrees. No? So this is not available in Cagayan de Oro. So the plan when the Pfizer vaccine will arrive in the Philippines was to give it to Manila, Davao, and Cebu, because these are the places where freezer that can store the vaccine at these temperatures are available. So the study was, the clinical trial was started in July of last year for the Moderna, and in their clinical trial, they enrolled 30,000 individuals. No? So 15,000 were given the vaccine, and then 15 were also given the placebo. So this was given to adults 18 years and older, and there were 47.4% females, and there were also individuals more than 65 years old who were given the vaccine. No? So 82% were considered at occupational risk for SARS-CoV-2, so like the healthcare workers. So the result of their trial showed a vaccine efficacy of 94.1%, occurring at least 14 days after the second dose of the vaccine. So that means that for those who are who's going to be potentially infected with the vaccine, for example, if you have 100 individuals, so you will prevent 94 to have the infection against giving nothing to these individuals, and they will experience the infection. Next is the Pfizer vaccine, so which is also an mRNA vaccine, also given for 2 doses, but the interval is 21 days. It's also given intramuscularly, but the storage is even at a lower temperature, so that's negative 70 degrees. And it is stored at 2 to 8 degrees for 5 days once thawed but undiluted. So the Pfizer trial enrolled 43,000 participants. So there were 18,000 who were given the vaccine and also 18,000 given the placebo. So this was given to adults 16 years old and above who were healthy or with stable comorbids, even including those who have HIV, hepatitis B, and hepatitis C. So the vaccine efficacy of Pfizer was at 95%. So for the AstraZeneca, which is an inactivated vaccine, so it is the use of the adenovirus for the AstraZeneca, and so the vaccine is given also for 2 doses, and the interval is between 6 to 12 weeks, and they have said that those who are given a longer duration interval confers better immunogenicity. So it's also given intramuscularly, and so there has been no EUA approval in the UK and the US, but they already submitted for approval in the Philippines. So we have the AstraZeneca, which enrolled 7,000 participants, and this was also given to greater than 18 years old, who with high risk of exposure to the virus, including healthcare workers. So their vaccine efficacy is at 70.4%. So for the Gamaleya vaccine, which is from Russia, so they also have, it's also given intramuscularly, and the storage is only at 2 to 8 degrees centigrade. So it's also given for 2 doses. And the efficacy of the vaccine is at 91.6%. So just like the other vaccines, the common local effects of the vaccine is really pain on the injection site. There may be swelling, and some patients may even have fever, but that's only a short time. Now we have the Novavax, which is a recombinant subunit. They make use of the spike protein. We mentioned that some vaccines make use of subunit only of the virus. So it's also given for 2 doses, 21 days apart. So better storage requirement at 2 to 8 degrees centigrade. And they have not released their data on the vaccine efficacy of Novavax. So it's still in the phase 1 and 2 of their clinical trial. So we have the Sinovac, which is the one that's going to be available for Cagayan de Oro, which is an inactivated virus. It's also given in 2 doses, given intramuscularly, and then the interval is between 14 to 28 days. So storage requirement is also better at 2 to 8 degrees centigrade. So that's the usual storage requirement that we have for most vaccines. And the efficacy of this vaccine, their data is still really not out, but some journals have said that the efficacy is between 50 to 60 for this vaccine. And the reactogenicity is also experienced, presenting being pain and swelling in the injection site, or we also may note discoloration or redness or even pruritus. And some patients may also present with systemic effects of the vaccine. This is a table comparing the different vaccines and their vaccine efficacies. So this is taken from another journal. This is from the WHO. So for the Sinovac, so this is still in phase 3. and data is not yet published, but the report efficacy is at 50% for mild, 78% for mild to severe. In Brazil, and 65% vaccine efficacy in Indonesia, and 91.25% vaccine efficacy in the study done in Turkey. So what are the adverse reactions to vaccines? So we have the reactogenic reaction, which is an inflammatory response that occurs after vaccination. So it occurs within the first 3 days after vaccination and resolves within the 1 to 3 days after the onset of the reaction. So reactions like pain, swelling, and tenderness on injection site are noted. And patients may also manifest systemic reactions, which is an effect of the release of inflammatory mediators as a reaction of the body to an invader, which is actually the vaccine or a foreign body, again, that's being injected into the body. So this may be seen as headache, fatigue, malaise, muscle pain, chills, fever, and vomiting. So we also have the allergic reaction, which is an exaggerated immune response to a usually harmless substance. So there's types 1 to 4 allergic reaction. So type 1 is the reaction that can manifest as urticaria, vomiting, abdominal cramps, rhinitis, and asthma, which can happen within 4 hours after exposure to an allergen. So anaphylaxis, which is the severe type of type 1 reaction, is rare. And for mRNA vaccine, it is noted at 11.1 per million dose. So it's not really very high, but yeah, that's the reason why we have seen some reports of people having these reactions when they were given the mRNA vaccines. And they can also manifest as pruritus, urticaria, flushing, angioedema, dyspnea, wheezing, vomiting, abdominal cramps, syncope, and hypotension, and tachycardia, or increase in the heart rate. So type 2 reaction can manifest as also as anemia, or thrombocytopenia, which may be noted later, after the injection of the vaccine. And anaphylaxis should be managed with epinephrine. That's the reason why it is recommended for vaccination sites to have epinephrine ready, and they have to observe those who have been injected with the vaccine for at least 30 minutes to an hour after the vaccination. So having all these vaccines that's going to be available to us, it's still important to make use of the other interventions to protect ourselves. So this is the Swiss cheese criteria, uh, interventions that we have in place, that we have to put in place to protect ourselves. So we have to exercise still the physical distancing, having a good ventilation in the areas where we stay, still wearing of mask, and hand hygiene and surface cleaning, and then testing of those who have been exposed or those with symptoms, and then to isolate and quarantine those with the disease or those who have been exposed. Then of course the government intervention should still be in place, and then we have the last, which is the vaccine. So even if we are already vaccinated, the experts still recommend that we have to still exercise the minimum health standard, which is the wearing of mask, hand hygiene, and the wearing of face shields. So I would like to end with what Dr. Tedros Ghebreyesus, the WHO Director General, said in one of his press conferences. He said, vaccines will help to save lives, but if countries rely solely on vaccines, they're making a mistake. So basic public health measures remain the foundation of the response to the pandemic. Thank you and good morning.
Daghan kayong salamat, Doc Arlene, for again strengthening our knowledge and our deeper understanding on the vaccines that are available and the reactions that may be possible as we proceed with the vaccination program. So now is the time for our open forum. But many of the questions that were raised again when we pre-registered, most of these questions have already been answered from the presentations of our two speakers. So, but there are some here that would need further explanations. One coming from Judge Borja. He said there's a 50% efficacy, effectiveness of Sinovac. Does it mean it works only 50% of the time, or that it works only up to 50% of the range of symptoms? So I think Dr. Gina wanted to answer this earlier. So any of the two can maybe answer this.
Actually, Dr. Obsioma was including it in her lecture, no? Katubitang mga data on pila kabuok ang population na gi test. But anyway, let me flash something on the screen. Wait. Share. Sorry. Where am I? Sorry. Do you see anything?
We see you.
Oh, okay. Sorry. I'm not good at this, no? Wait, I'm lost. Sorry. Share screen. Oh, there you go pala. Share. Okay. So I think, can you see the...
Yes, Doc, Manalo.
Can you see the slide? Okay. So
on mine, no. It's okay.
Basically, part of the trials, no? You remember Doc Arlene was talking about phase 1, phase 2, phase 3, and there's even a phase 4 trial, no? In phase 3, what happens is there is a clinical trial where there is a group that is vaccinated and there is a group that is not vaccinated. So the efficacy is actually a comparison of the risk among the unvaccinated group minus the risk among the vaccinated group over the risk among the unvaccinated group. I did not want to go into this kasi it turns many people off, no? Kanang mag-istorya na ganit mathematics, di na gusto maminaw ang mga tao. So 96% efficacy rate means the vaccine reduces the risk of having disease by 96% in the vaccinated group compared to the non-vaccinated group. So this is efficacy. How it will behave in a real situation when it is used in the community is everybody's guess. Kung maupa paghihapon ni ang efficacy, we don't know, no? Effectiveness, we don't know. Right now, that nobody, no pharma company can answer effectiveness rate because there is not enough data. What everybody needs to understand is that when the pandemic hit us, all the research that had to go with the development of a vaccine actually was cut short, no? Shortcut siya tanan. So there are many things we cannot answer. And it is that, no? It is, you take it or you leave it. Kasi wala gyoy tubag ang daghang pangutanaan eh. Because we are, Doc Arlene again mentioned this earlier, if this were a normal research, it will take between 5 to 7 years. No? So right now, if I ask people, when do we get the next round of the vaccine? No, because like for example, flu vaccine, we have it every year, di ba? Ang coronavirus vaccine ba every year gihapon? Nobody will be able to answer you that because we don't know. What is going to happen is if enough people are vaccinated, later on people will have to submit to a titer, no? the titer of antibodies will have to be determined, and then experts will tell us whether we need the vaccine again or not. So this is just what I want to, the end, the takeaway message is there is nothing really very sure yet, no, except for the fact that most of the vaccines that have been given EUA are at least effective in first preventing the disease or preventing the severe form of the disease so that we can get the disease in a mild version, and so we do not die. Attorney Borja actually had a question related to that, no? Wait, let me just stop sharing. Okay, I forgot. Attorney Borja, can you ask the question again? It's not on my screen anymore. You had a question about herd immunity and he had a question about will it affect herd immunity? No, may isa. Katong will it affect herd immunity?
Doc Borja,
my related
Judge Borja,
my related question is, I think there is no question that the vaccine can provide individual immunity, but the reports from media are saying that it may protect you from getting the severe symptoms of the disease,
yes,
but you may remain a carrier and therefore may be able to
yes,
transmit it.
Yes.
It suggests to me, and I'm a layman here, no? It suggests to me that it definitely works on an individual basis, but may not induce a herd immunity because you can still transmit it. And everyone who may be immune individually may still be a carrier and transmit it. At least that's what CNN and the other news, BBC and the others are reporting. If that is true, how does that affect herd immunity? It does not mean I don't want it, no, but I'm just curious how it will affect the general community. Thank you very much, Doctor.
Exactly, no? Exactly. That's why, again, this is one of the unanswered and the impossible to answer questions. When we are asked, when do we achieve herd immunity? I will really tell you, I don't know. Because exactly, the point of Attorney Borja of Judge Borja is that if the vaccine prevents only the severe form of disease, therefore, I can, even if I'm vaccinated, I can still transmit and in fact, I can still get sick of the disease, but I will get the milder form. And so, because makatransmit pamangkot, I do not contribute to herd immunity. Exactly. Kaya nga, it's difficult to, again, these are things that we cannot answer in exactly, no? Kanang dili ta ka makomputan, dili ka makomputan din unya makasulti ko sa imo nga by 1 year or by 2 years ma-achieve na nato ang herd immunity. But certainly I am having myself vaccinated because I think it is better to protect myself than not to protect myself. Nakaantos naman tag more than a year nga walay protection. So, bisag 50% efficacy, I will submit to it. No, I will submit to it.
Okay.
Better than none. Maayo na lang na kaysa wala.
Sige. Thank you, Doc Gina. Doc Arlene, would you like to add in something to that, to the answer of Doc Gina?
Yeah. Well, it's true, no? I'm not sure if I got Judge Borja right when he said that there is a concern of becoming a carrier after being vaccinated, carrier of the virus after being infected. Not sure if that what he meant, no. But I think that's not true, no? That the individual will remain a carrier of the virus, because as was mentioned in the lecture, the viral shedding will start to decline even on the first day when the symptoms happen. And then, so it ends, as was seen in the different trials, the isolation of the virus usually does not happen anymore after 8 days from the onset of symptoms. So I don't think the question of being a carrier has really a basis. No? And then I agree with Dr. Gina, no, that it's really better to be protected from developing the severe disease. No? So if you are one of those who see these patients with severe infections and you see these patients every day, you would really want people not to experience this. No, so if there's a vaccine that can be given to prevent people from developing these severe infections, then for me that would really be good. No, because if you will still have the infection but just have the mild disease, that's just like an ordinary flu, then that's really okay. So even if, that's why we also mentioned earlier on that even with the vaccines and all that we have, we still have to institute the minimum health standards, that so it should still be in place. We should still make use masks, wear our face shields, wash our hands, no, because as Dr. Jean has mentioned, many questions are still being answered by different studies, no, so we still have to learn many things. But while we wait for all this information and there's this data, then we have to practice these minimum health standards to protect ourselves still.
Okay. Thank
Thank you.
you, Doc Arlene. So I
Thank you
think
very
the
much.
answers are very clear. So maybe we can proceed to the next one. This one from Sir Bibal. He asks, is it possible that some persons have already developed antibodies against COVID virus? So for example, he said, I have natural antibodies against hepatitis, so I was not vaccinated for hepatitis. A test was conducted before immunization. So is it possible?
Yeah, yes, it is possible. Our body will develop antibodies only
Yes,
when it
possible.
is exposed to an antigen. So when you have an antibody against the hepatitis, even if you were not immunized, that means you have been infected at some point in the past. But your immune system was able to fight the virus, so you have now your antibody. So it is, yeah, possible for individuals to have antibodies against the coronavirus, the coronavirus when you get infected. And we have mentioned that there are asymptomatic individuals, so we really do not know. No, so that's why there's a question whether should we screen all individuals if they have antibodies, and then after the screening, should we just give the vaccine to those who have not been exposed or who have not been immunized? But that will really take time because there's still, that will entail cost of the testing for the antibodies, and then that will take, grabe ang logistics and all. So it will delay even more the giving of the vaccine. So there's really no concern if you have had a previous infection. No? At present, they say even if you have had infection, then you may still be given the vaccine. So it's really still safe, no? If you have had an infection in the past, no? If you have a symptomatic infection and then you are given the vaccine. So studies have shown that that's really still okay, no? To give the
Yeah.
vaccine to these individuals.
Okay, thank you very much. To just to manage time, maybe one or two more questions. Some can be collapsed. Many of the questions that are here are really are asking about the adverse effects of the vaccine, no? Once one is subjected to the vaccination. So that was answered in the presentation of Doc Arlene earlier. So here lang are some of the questions that are still being raised. My mother is undergoing cancer treatment. Would you advise her to get vaccinated? And is there a need for an assessment of a patient's health status before the vaccination? So either Doc Gina or Doc Arlene may answer the question.
Okay, I'll answer. For the first question, it's best for the attending physician of the patient to really assess whether it's safe, no, because it's not uh, right, and it's not easy, no, to just say, I have a patient, I have a mother with cancer, and then can she be immunized? Because the doctor really has to assess. No, there may be still tests to be done to really assess if it's really safe for the patient to be given the vaccine. So for the second question, yes, the DOH, I think, has a pre-assessment assessment form prior to immunization. So all individuals should be assessed their health status first prior to giving the vaccine, because we need to know whether they have comorbidity, whether they have allergies, history of allergies. So this has to be done prior to the immunization.
Yeah, Doc Gina, would you have something to add to Doc Arlene's answer? Thank you, Doc Arlene.
I was about to ask also, to ask her also. I told her I will ask her because I have a brother who is immunocompromised, no, who is taking tacrolimus because of
Yeah.
kidney transplant. Which which type of vaccine would you recommend that he gets? I I remember reading somewhere and I don't remember now na sila gi-recommend para sa sa inani nga pasyente no immunocompromised. One of the vaccines you talked about, I can't recall anymore which one it was that they were recommending that he gets. Do
Doc, in the
you have an
presentation,
answer to it?
yeah, in the presentation, it was mentioned that in the Pfizer trial, they included some immunocompromised individuals, those with HIV.
Immunocompromised, yeah.
Yeah. So I think it's the Pfizer, but for
The
the
Pfizer.
activated,
Pfizer.
no, activated was in immunocompromised, the concern really is if their immune system is not good, and then they will be given the live, vaccine, then this might
Okay,
cause
yeah.
severe infection in these individuals. But if it's
Infection,
killed
yes.
or inactivated, then it should be safe to give to these individuals. The problem only with those with immunosuppressants is the question of whether their immune system will really be able to mount a good response against these
Yeah,
vaccines.
yes.
So that still has to be answered by the different studies, though.
Yes. Actually,
Okay.
nobody could give me a straight answer, no. But again, it's something that we still do not know the exact answer to. So, but basing on literature, there have in Singapore, for example, they have given Sinovac to to patients who have undergone kidney transplant, and they were okay. Nothing happened to them.
Yeah. Sige, so maybe, Doc Gina, that is also one among the many things that are left unanswered at this time, no? In the development of the current available vaccines in the market. So sige, that is one among those. So thank you very much, no? Judge Borja has another question, and many of the questions that were raised actually were in terms of like, is there a vaccination program in XU? Do the employees get the vaccine for free and things like that? But the doctors, our resource persons, will not answer that anymore. That will be left to our kind of closing message by our VP Sasoy later. So that one, the next steps for XU to take maybe, and these questions on how employees and even students will be able to avail of this will be answered. So there might be other questions that are not yet answered here, but we can raise this again with you, Doc Gina and Doc Arlene, through email and other forms of
Yes, yes,
communication and social
yes,
media, and then we will get this back to
yes.
you, to the ones who asked the question for maybe possible answers. But if there are no answers yet at the moment, then That's just it. We will still say it's not yet possible to answer the question. So thank you very much. Doc Gina and Doc Arlene, si Sir Ed Sasoy will also, on behalf of XU, will thank you officially after he delivers his closing message and the immediate next steps for Xavier University. So can we all give Doc Gina and Doc Arlene of Shoma a virtual round of applause? Oh, happy birthday, Doc Arlene. It's her birthday. Have a COVID-free birthday, Doc
Birthday.
Arlene. Sige. So, Sir Ed Sasoy, our VP for Administration, will now give the closing message and again, the next steps for XU to take in this vaccination plan. No? So, thank you. Sir Ed?
Yes, thank you, Gail. So, good morning, everyone. Udto na, no? Paniudto na. Thank you for attending our first COVID-19 vaccination webinar. Since the expected arrival of the vaccines will be at the third quarter of this year, we will continue to provide venues like this so we can all be informed of new developments related to our vaccination program and, of course, the availability of vaccines. To succeed in our fight against COVID-19, we have to have the same shared objective of achieving herd immunity as emphasized by Doc Gina and Doc Arlene in their presentations. Our way of proceeding will be including the following activities. No? First, I'd like to request that all unit heads will perform or conduct a unit level discussion of vaccination concerns. Units, for example, like PPO, CISO, Basic Ed, as well as Higher Ed units, uh, to meet and discuss individual concerns about the vaccination, to resolve individual concerns like doubts, for example, or hesitations about individuals getting vaccinated. We will give ample time for the units to do this. I would like to request the concerns not resolved during these meetings be cascaded to the committee for possible resolution. Second, we will conduct an online survey to get the community's pulse on the probable issues and concerns that hinders the acceptance of vaccination. From the result, we will provide targeted infographics to provide more information addressing majority of these concerns. We will also provide FAQs, no? Both videos and text, and post them in our websites for everyone to see and read. Third, we will also constantly update everyone on new developments. For example, new vaccines on phase 3 trials, vaccines given EUA or emergency use authorization in the Philippines, and promising vaccines being developed that XU can probably order on the near future and use for our program. Fourth, the committee will also find ways of enhancing this vaccination program considering the resources of the university and employees. No? There is a question kung makahatag ba for free. No? I hope makahatag for free, but nato sa tay problema no, sa ato ang panudlanan. The committee will explore creative ways of trying to fund our vaccination program. So at this point, I would like to thank our resource speakers for their time and effort to address the learning needs of the XU community about this very important endeavor. Doc Gina and Doc Arlene, thank you very much. The Social Development Cluster also for hosting this webinar headed by VP Roel Rabanera, of course, Gail, Becky, and the SD team, and also the members of the committee who helped in making this webinar a success. Thank you very much.
Thank you very much, Sir Ed, our VP Ed Sasoy. Thank you. So again, vaccination is important to attain herd or community immunity against the virus. The more people get vaccinated, the more barriers for the virus to get transmitted and eventually will help end the pandemic. So basic prevention, health prevention, and protection is still highly advised. No, better get the vaccine, according to Doc Jojo. Better get the vaccine than get the virus. Sige, hopefully, Atenista, Pabakuna ta. Let us continue on with the vaccination program that gets strengthened as what Sir Ed earlier said. So So kamulo pang ipanday gihapon ang pag-strengthen sa vaccination program for Xavier. So hopefully, again, this is not the first webinar that will tackle this, but there will be other webinars as well. So thank you very much, everyone.